it's nice to meet everybody. I'm coming in from FAU in Florida. So the case that I'm presenting today is one that I saw during my cardiology rotation towards the end of my intern year. So essentially, it takes a look at the correlation between intracranial pressure that is increased and prolonging the QT interval, as well as connection between other cardiac markers. So just to kind of first explore the relationship between the two. So it's been known that a neurogenic cardiac injury is something that can occur when you have an event that affects the neurological system. So whether that is a stroke, a TIA, increased intracranial pressure due to uncontrolled hypertension, or a seizure can cause some sort of an abnormality in cardiac function. The reason that this usually occurs is that when there is an issue in the neurological system, there is a release of catecholamines, depending on what they are, that can cause dysregulation in the autonomic nervous system, and then thereby lead to myocardial injury as well. So a cardiac injury, the way that it can present, as everybody I'm sure knows, can be in EKG changes such as ST or T wave changes, elevation in cardiac markers such as troponins, abnormal rhythms, or QT prolongation. So for our case report, we focus specifically on the correlation between QT prolongation and elevated intracranial pressure. So in terms of the QT prolongation, it would differ slightly for men and females. So greater than 450 for men, greater than 460 in females. And we know that the rise in intracranial pressure leads to abnormal ventricular repolarization because it causes an influx of the catecholamines, neural stimulation, which then can prolong the QTC, and thereby lead to possible potentially dangerous ventricular arrhythmias and even sudden cardiac death. So it brings me to the case that I saw during my cardiology rotation. So we had a 75-year-old female. Past medical history was hypertension as well as a stroke that caused her to have bilateral neurological deficits, residual deficits, including a right-sided facial droop as well as left-sided weakness. When she came to the emergency room, her main complaint was just some fatigue, lethargy, a little bit of weakness that was occurring for about 2 days. And the only other symptoms that she endorsed at the same time were some palpitations as well as a headache. There was nothing that she was able to take at home that was relieving the headache. And she says that she was compliant with the medications that she was taking for her hypertension, no reported non-compliance. So when she came to the emergency room, her initial systolic blood pressure was 230. There were no new focal deficits noted on physical exam for her, neurologically speaking. And in terms of her heart sounds, there was an irregular rhythm on initial presentation. Her labs were only significant for some hyperglycemia, but besides that, all of her electrolytes were within normal limits. And her initial EKG showed some premature atrial contractions, and there was some QT prolongation noted as well. When we did a CTA for her head and neck, she had 70% stenosis of the left carotid and 50% stenosis of her right carotid. At the time, we initially believed that she may be undergoing a possible TIA given her past history. However, after she was admitted, several hours later, she did have an MRI that ruled out any evidence of a stroke or TIA, and she, as I said before, never really had any focal deficits. We did order a repeat EKG approximately 8 hours after her initial presentation in the ED, and it was noted to have worsening QT prolongation. So we admitted her for her hypertensive crisis, and we were suspecting that the worsening of her QT prolongation had to do with the fact that her intracranial pressure was likely very elevated given her blood pressure. We calculated the cerebral perfusion pressure, which for her was 133 over double the normal range. So taking a look at some of the studies that have been done on this, we've seen that QT prolongation can be used as a prognostic indicator for how severe a patient may have a cerebral contusion. And in this study, specifically that was retrospective, they took a look at prolonged QT intervals, and they associated it with a higher risk of greater midline shift, larger contusion volume, and increased mortality in patients that had a TBI. There was also another study that we took a look at that wanted to compare how effective it was to do a decompressive craniotomy for those that had very severe intracranial pressure. And it was noted that it could result in the decreasing of a QT interval that was seen at that time. Their study was noted to be statistically significant, and it found that the decompressive craniotomy actually did successfully shorten the QT interval. So to kind of wrap up what happened with our case, so we were trying to control the patient's blood pressure, which took at least 24 hours to start getting some response into it. We had started her on a new regimen of lisinopril, metoprolol, and hydralazine. The only medication that she was taking outpatient, which was controlled by her primary, was the lisinopril. So we increased the dose for that and then added the 2 other medications. We did do a repeat EKG, which showed resolution of the QT prolongation. It was decreasing. So the 2 EKGs that you see at the bottom of the left screen, one shows the initial and one shows the final EKG that was done. However, there were interim EKGs that were also downtrending. And so, based on that, we concluded from this case study that QT interval can be a valuable resource for us physicians in order to kind of correlate how severe a patient's intracranial pressure may be with uncontrolled hypertension. Of course, some barriers to this or some obstacles would be that there are other factors that could contribute to the prolonged QT interval, including medications, underlying arrhythmias, any sort of congenital syndrome, as well as electrolyte derangements. However, given in our studies that there were none of those factors present, we concluded that it was likely secondary to the elevated intracranial pressure in the setting of uncontrolled hypertension.